This session is session 7 and it is on lymphoproliferative and plasma cell disorders. We've got a great lineup of talk coming up. Few house rules. I will be receiving questions and I will take them at the end of the session. We will be starting off with free papers, but before that, I would like to introduce our panelists. Dr. Syed Waqas Imam Bokhari, who has joined us at the moment, and Dr. Waqas is a consultant clinical hematologist and he is affiliated with Shahzad Memorial Cancer Hospital. We also have with us today Dr. Imran Nazir Ahmed, who is a pathologist at Shifa International, and I'm sure Dr. Imran will join us in a few seconds. And last but not the least, we also have Dr. Shahzad Nasir as a panelist today, who is a consultant hematologist and he is affiliated with Quaid-e-Azam International Hospital. To start off the program, we first have free papers, and the first presenter today of this session for free paper is Dr. Mohammad Yousaf, affiliated with Rawalpindi, Pakistan, and he is going to talk on outcome of hairy cell leukemia patients. This is going to be a 16-year experience of a tertiary care center in Pakistan. Dr. Yousaf, over to you.
Aslam alaikum. I'm Dr. Mohammad Yousaf, resident clinical hematology at AFBMTC. Today I'm going to talk about outcomes of a hairy cell leukemia patients, a 16-year experience of a tertiary care center. To start with, hairy cell leukemia is a rare B-cell lymphoproliferative disorder which is characterized by various degrees of pancytopenia, typically hairy cells in the peripheral blood or bone marrow, splenomegaly, and hepatomegaly. Characteristic markers expression on immunohistochemistry and flow cytometry, and BRAF mutation. Not every patient of hairy cell leukemia needs treatment. The indications need at least one cytopenia and organomegaly. Treatment options by 1984, splenectomy was the only option we had for hairy cell leukemia. Then interferon was introduced, though interferon had infrequent and short-lived complete remission. The newer treatment options, we have nucleoside analogs such as pentostatin and cladribine. The objective of my study was to document the outcome of hairy cell leukemia patients treated at AFBMTC. So a retrospective study was designed which included patients from 2004 to 2020, as the first patient of hairy cell leukemia presented to AFBMTC was in 2004. The study was conducted at AFBMTC. A total of 26 patients till date has been reported to AFBMTC. All the record files of the patients presenting to AFBMTC with hairy cell leukemia were included in the study, and only the files who had insufficient data were excluded from the study. To measure the outcomes, we have distributed the patients in broadly two different categories. One with overall survival, overall remission assessment response, and the other one is relapse. With overall response, we have two subcategories with complete remission and the partial remission. By complete remission, we mean resolution of organomegaly on examination, resolution of cytopenias, and absence of hairy cell leukemia. By partial response, we mean at least 50% reduction in the palpable hepato or splenomegaly, more than 50% improvement in the peripheral blood, and more than 50% reduction in the number of circulating hairy cells. And by relapse, we meant development of new or progressive peripheral cytopenias, reoccurrence of splenomegaly, or new clinical symptoms attributed to hairy cell leukemia. So the results of my study were, we have basically 3 female patients and 23 male patients with a median age of 48.12 years. On presentation, we have noted that the majority of the patients presented to us with generalized body aches, followed by abdominal discomfort, which is secondary to hepato or splenomegaly. By this data, while analyzing this data, we came to know around 11% of the patients presented as an incidental finding of cytopenias. When we discuss about the organomegaly, so on analyzing the data, we have, as we can see, majority of the patients presents with hepatomegaly, presenting to AFBMTC had hepatomegaly rather than the splenomegaly. These are the presenting counts, presenting total leukocyte count. As you can see, majority of the 50% of the patient presenting total leukocyte count less than 4, and total absolute neutrophil count less than 0.5. Presenting hemoglobin levels, 58% of the patients presented with a hemoglobin level in between 8 to 12 gram per deciliter, and presenting platelet count, majority of the patient had less than 50,000 platelet count. So the treatment options we offered to the patients were included splenectomy, cladribine, CHOP therapy, CVP, and 3 patients had were offered cladribine, but due to some miscellaneous issues, their treatment is still awaited. As you can see, majority of the patients who received cladribine, around 91% or 91.6% of the patients responded to the treatment, while only 2 patients did not respond to the treatment. The patients included in the splenectomy group, around 71.4% of the patients responded to the treatment, while no patient, we have only 1 patient who received CVP as therapy, first-line therapy, and he did not respond to the treatment. Those patients who had splenectomy as their initial treatment, out of those, 2 did not respond to the initial therapy. So both of them received, one of the patient received cladribine, the other patient received CHOP therapy. Patient 1 who received cladribine had clinically improved, but their formal assessment of remission is still pending, while the patient 2 was lost to follow-up. That patient who received cladribine as initial therapy but did not respond, received CHOP therapy as their salvage therapy, but did not respond to CHOP as well. And then the patient lost to follow-up. The only patient who received CVP as their initial therapy received cladribine as their salvage therapy, and then he did not show up in the OPD. On inquiry, we came to know that he was no more since 2012. As far as relapse rate is concerned, as the graph shows, the cladribine group has the minimal relapse rate of 18.18%, followed with splenectomy of 20% and CHOP therapy of 50%. Those patients who relapsed, they received cladribine as their, those patients who relapsed among the splenectomy group, they received cladribine as their salvage therapy, and they achieved remission. Those who received cladribine as their initial therapy and they relapsed, they received cladribine plus rituximab for their salvage therapy, and they achieved remission as well. The only person who received CHOP therapy and who relapsed received cladribine, and then he did not show up. Overall survival, as a median of 4.6 years, the overall survival with cladribine was 100% at our center, with 85% with splenectomy, and 50% with CHOP therapy. These are the few international studies which report the response rate, complete remission with cladribine. Our study report around 91.6% of complete remission, which is very much comparable to the international data. These are the 3 studies conducted in Pakistan with cladribine reporting the complete remission rate of 85.71% or 98%. Our study reports 91.6%, which is very much comparable to the local study as well. So hereby I conclude, the cladribine demonstrates highly impressive activity against HCl. A single course of cladribine was able to induce complete remission in vast majority of the patients. Patients who relapsed were successfully treated with cladribine and rituximab. Thank you.
Thank you, Dr. Yousaf. We're going to take questions in the end. So I will let you know if I receive any questions regarding your presentation. So that is it for now. Our next presenter for the pre-paper category is Dr. Javeria Jamal, affiliated with AFIP Rawalpindi. And Dr. Javeria is going to talk on spectrum of molecular cytogenetics and chronic lymphocytic leukemia.
Assalamu alaikum. My name is Dr. Javeria Jamal. The title of my study is Spectrum of Molecular Cytogenetics in Chronic Lymphocytic Leukemia. Chronic lymphocytic leukemia, or CLL, is a lymphoproliferative disorder that is due to the accumulation of mature B lymphocytes in the bone marrow, peripheral blood, or lymphoid tissues. It has a variable course of disease, and a number of cytogenetics and a number of prognostic markers have been identified, of which the cytogenetics plays a very important role. Among these included are deletion 17p, deletion 11q that carry a poor prognosis, trisomy 12 that has an intermediate prognosis, normal karyotype, and deletion 13q which has a good prognosis. Deletion 17p involves the short arm, the p53 locus on the short arm of chromosome 17. Whenever there is DNA damage, the p53 arrests the cell cycle and repairs the DNA. If the DNA cannot be repaired, it leads to apoptosis and elimination of the damaged cells, thus thereby maintaining cellular and genetic stability. Loss of p53 function leads to proliferation and survival, genetic instability, drug resistance, inhibition of apoptosis, angiogenesis, all leading to tumor initiation and progression. Deletion 13q. Deletion 13q has a good prognosis if it is detected as the sole aberration. Its pathogenic role is due to the deletion of DLEU2, MIR15A, MIR161 locus. This leads to the overexpression of BCL2, which has increased anti-apoptotic activity. This leads to increased lifespan of B cells. 11q gene deletion leads to the loss of ATM gene. The ATM gene is the principal DNA damage response gene, and it also phosphorylates p53 whenever there is DNA damage. Loss of ATM gene leads to functional deficit and chemoresistance. Trisomy 12 detected at the time of diagnosis confers an intermediate prognosis. Atypical morphology defined as the presence of cleaved nuclei or lymphoplasmacytoid cells is seen in patients harboring trisomy 12. These patients usually have advanced disease. These are the two techniques that are used to detect cytogenetic abnormalities. The low mitotic index of CLL cells made the use of metaphase cytogenetics difficult. The analysis of chromosomal aberrations, the analysis of aberrant chromosomal regions using specific DNA probes through FISH or fluorescence in situ hybridization studies has made it possible to detect clonal aberrations in more than 80% of the CLL patients. This pyramid explains the hierarchical relationship of cytogenetics abnormalities with prognosis and outcome. Now I present my study. The objectives of my study are to study the molecular spectrum of chronic lymphocytic leukemia patients, to assess the clinical parameters in each cytogenetic subgroup, to evaluate the hematological parameters of our cohort of patients, and to follow up these patients to determine the event-free survival and overall survival. This ongoing cross-sectional study was started in January 2013 and is being conducted at the Department of Molecular Haematology at AFIP Rawalpindi. Patients were diagnosed as having CLL based on IWCLL criteria defined as the presence in peripheral blood of at least more than 5 × 10⁻⁹ monoclonal B lymphocytes persisting for at least 3 months, demonstration of the clonality of the population, and a characteristic immunophenotype with weak positivity for a surface membrane immunoglobulin, positivity for CD5, CD19, and CD23, and weak positivity for CD20. All newly diagnosed CLL patients were included of all ages and both genders. Patients on treatment or patients of other lymphoproliferative disorders were excluded from the study. This is the algorithm that I followed. Detailed history and examination was taken. Baseline laboratory investigations were performed. After bone marrow examination, cytogenetics and FISH studies were analyzed. Patients were followed up for a period of 36 months. Fluorescence in situ hybridization studies were performed. 3 ml blood was collected in sodium heparin. After harvesting, the slides were prepared. 10 microliter probe was applied to the target on the slide. After denaturation, hybridization, and co-denaturation, a total of 500 nuclei were analyzed per probe set on fully automated FISH analysis system. The probe for deletion 11q and deletion 17p targets ATM-TP53. A green labeled probe hybridizes to the ATM region at 11q, and an orange labeled probe hybridizes to the TP53 gene region at 17p. In this image, ATM-TP53 hybridized to bone marrow cells. 4 interfaces are shown. C and D shows normal pattern with 2 green and 2 orange signals. However, in A, there is loss of one green signal, which signifies the loss of ATM gene, while in B, there is loss of 1 orange signal showing deletion of 17p. The probe for deletion 13q and trisomy 12 consists of a green label probe hybridizing to the centromere of chromosome 12, an orange label probe that hybridizes to the DLEU MIR15A MIR161 gene region at 13q14, and an aqua-colored probe that hybridizes to the LAMP1 gene region at 13q34. In this image, the probe hybridizes to the bone marrow cells, and 3 interfaces are shown, of which 1 shows a normal signal pattern with 2 blue, 2 green, and 2 orange signals. The cell labeled as A shows 2 green, 2 blue, and only 1 orange signal that signifies the homozygous deletion of DLEU MIR15A MIR16 gene region. In B, there are only 2 green and 2 blue signals that signifies homozygous deletion of the DLEU MIR15A MIR161 gene region. Follow-up of the patients was carried out for 36 months. Event-free survival is defined as the time period from diagnosis to the date of the event, and overall survival was defined as the time period from the date of diagnosis to the date of death. Our data analysis is as follows. This column graph shows the age distribution of patients included in the study. The pie chart indicates that 79.1% of the patients included in the study were males. Our study shows that 25% of CLL patients had deletion 13q, which was closely followed by deletion 11q and deletion 17p. Median age of CLL patients were with 1 or more cytogenetic abnormalities was in the range of 56 to 68 years. And in this group, again, the males were predominantly seen. This is a tabulated form of the different clinical parameters that were evaluating during the study. Majority of the patients who were asymptomatic showed deletion 13q. Lymphadenopathy was seen predominantly in deletion 17p. Likewise, poor ECOG score was seen in majority of the patients with deletion 17p. According to the Binet staging system, patients with deletion 17p presented in stage C, while patients with deletion 13q presented with stage A and B almost equally. The hematological parameters showed that the WBC count was significantly higher in deletion 17p, while patients with 67%, approximately 67% patients presented with atypical morphology in trisomy 12. No statistically significant association was seen with CD38 and ZAP70 in any of the cytogenetic subgroups. Majority of the patients of deletion 13q did not require treatment at diagnosis, while those with deletion 17p and 11q required treatment. This is a Kaplan-Meier curve that gives us a visual representation of the probability of event-free survival of the different cytogenetic subgroups. After a follow-up of 36 months, the overall survival of patients harboring deletion 17p was 62.2%, while patients with deletion 11q who had an overall survival of 77.3%. That of trisomy 12 was 83.3%, those with normal karyotype was 85.4, and the patients with deletion 13q had an overall survival of 87%. In comparison with international data, the frequency of cytogenetic mutation detected in our population was 47%, which is comparable with the study in Poland. However, much higher frequencies have been reported in the British and Indian population. Deletion 13q was the commonest mutation found in our population, which is consistent with other studies. Deletion 11q was at 16%. Deletion 17p was found to be 14% in our population. However, very low frequencies of trisomy 12 have been reported in our population as compared to studies from other countries. The conclusion of my study is detection of molecular cytogenetic abnormality is pivotal in the management of CLL patients, predicting disease course and tailoring therapeutic regimes. Thank you.
Thank you, Dr. Javeria. Quite an interesting paper over there. Our last presenter for the free paper category in this session is Dr. Mohammad Shabih Haider, and Dr. Haider is going to talk on autoimmune cytopenias in chronic lymphocytic leukemia.
I'm very sorry, there is a problem with opening of the presentation. I would require just 2 minutes.
So while Dr. Haider's presentation is being fixed, I would once again like to introduce our panel experts in today's session. We are pleased to have with us Dr. Syed Waqas Bokhari. Dr. Waqas is a consultant clinical hematologist from Shaukat Khan Memorial and Cancer Hospital. We also have with us Dr. Shahzad Nasir, and he's a consultant hematologist who is affiliated with the Quaid-e-Azam International Hospital. And our last panelist in this session is Dr. Imran Nazir Ahmed, and he's a pathologist at Shifa International Hospital. So Dr. Shahzad and Dr. Waqas, while the presentation is being fixed, can I quickly ask Dr. Waqas, you, as to how has been your experience in treating patients with CLL so far in Pakistan with chemoimmunotherapy?
Thank you, Dr. Natasha. Can you hear me clearly?
Loud and clear.
Okay. So I think we all know that in Pakistan, where we have a lot of financial issues, and particularly myself working in an organization and a hospital which is based on donations and providing free service and treatment to a lot of patients. So we have to obviously take that into consideration. Still, I think at this point in time, our first line treatment option is heavily based on immunochemotherapy with rituximab in combination with FC in a young and fit individual. We have access to bendamustine and rituximab in those individuals who have renal impairment or we feel are older and unfit for FCR-based treatment. So although we all know there is a lot of excitement about novel treatments such as BTK inhibitors and venetoclax and others, at this point in time, we do not have a lot of access to these expensive but very promising medications. So that is what we have. We do check for 17p deletion or p53 mutation at baseline, and certainly those who have p53 mutation, we would recommend them to go on ibrutinib or a BTK inhibitor if they can afford it. And certainly that's our first line in that category of patients.
Thank you very much, Dr. Waqas, and we're certainly going to touch base with you once all the presentations are over, and we'll come back to that update again. Thank you so much. So I believe Dr. Shabih is ready to go now. So over to you, Dr. Shabih.
Thank you very much, ma'am. I'm very sorry for the inconvenience. I would start off. I'm Dr. Mohammad Shabih Haider. I'm a resident in Hematology in Armed Forces Institute of Pathology. And the topic which I'm going to present is autoimmune cytopenias in chronic lymphocytic leukemia. Chronic lymphocytic leukemia is a significant subgroup of chronic leukemias in adults. CLL patients present with lymphadenopathy and peripheral blood lymphocytosis, which is immunologically characterized as CD5 positive, CD19 positive, and CD23 positive. These lymphocytes are morphologically small and mature lymphocytes with a narrow border of cytoplasm, but functionally incompetent. Smudge cells are also seen in the peripheral blood. This is showing the peripheral blood in a patient of chronic lymphocytic leukemia, in which we can see the lymphocytosis and which we can see the smudge cells. This is the bone marrow aspiration in chronic lymphocytic leukemia, in which we can see the predominance of lymphocytes and depression of the myeloid and erythroid series. Chronic lymphocytic leukemia patients can present with autoimmune disturbances. These autoimmune disturbances include autoimmune hemolytic anemia, immune thrombocytopenic purpura, pure red cell aplasia, and autoimmune granulocytopenia. In a study which was conducted by Mayo Clinic, published in 2009, 4.3% of the cases with CLL present with autoimmune cytopenias. St. Paul Hospital, Spain reported a frequency of 7% in 2010. Among these cytopenias, autoimmune hemolytic anemia is the most common. A number of studies from the West reported a frequency of 3.7 to 7.7%. Despite a number of studies from the West, very few studies are available in the Asian population. A study was conducted at Karachi, Pakistan, and it found that the direct Coombs test positivity in CLL patients from southern belt of Pakistan was 23.3%, which is a remarkably high figure. In a similar study from India, there was a reported frequency of 3.1%. Being in the same geographical area, these two studies are not in agreement. These findings suggest that it is imperative that a fresh thought should be given to the frequency of autoimmune hemolytic anemia in patients of CLL. Immune thrombocytopenic purpura is the second most complication which occurs in CLL patients. In a study conducted by Mayo Clinic in 2009, 2% of the cases with ITP presented with CLL. St. Paul Hospital, Spain in 2010 reported a frequency of ITP as 1.14%. Pure red cell aplasia and autoimmune agranulocytosis are relatively rare complications in chronic lymphocytic leukemia. In a study conducted by Royal Marsden Hospital, United Kingdom, published in 2008, the prognostic effects of positive DAT in patients with CLL treated for the first time was assessed. A positive DAT predicted a poorer response to treatment, and together with autoimmune hemolytic anemia was associated with a lower overall survival. In terms of ITP, a study was conducted in Italy in 2008, which reported that this complication was associated with poor outcome in the CLL patients. The rationale behind my study was that it helped in distinguishing autoimmune cytopenias from cytopenias due to bone marrow infiltration, as management of both these types of cytopenias is fundamentally different according to the International Workshop on CLL 2008 guidelines. This study also helped to channelize the therapeutic resources for management of these cytopenias and improve the quality of life in these patients. So, coming to the objective of my study, it was to determine the frequency of autoimmune cytopenias by standard laboratory tests in diagnosed patients of chronic lymphocytic leukemia. It was a cross-sectional study which was carried out at Department of Pathology, Army Medical College, AFIP Rawalpindi, and Oncology Department, CMH Rawalpindi, and study was completed within 1 year. Confidence interval was kept as 95%, anticipated population was 4.3%, absolute precision was 5%, and estimated sample size using the WHO calculator was 64. And the sampling technique which I used was non-probability purposive sampling. In the inclusion criteria, all the diagnosed cases of chronic lymphocytic leukemia without previously known autoimmune disease or chemotherapy during the last 1 month were included in the study. Both males and females were included in the study, irrespective of the age, marital status, and the advancement of disease. In the exclusion criteria, all the patients with previously known autoimmune diseases such as rheumatoid arthritis, systemic lupus erythematosus, Graves' disease, Hashimoto thyroiditis, and type 1 diabetes mellitus were excluded. Data collection permission from the Institutional Ethical Committee was obtained for the study. Informed consent was taken from all the participants, and demographic characteristics such as age and sex was recorded. This is how the sample collection was done. 9 ml of venous blood were drawn under sterile conditions. 5 ml were transferred to EDTA tube and stored for complete blood counts, peripheral examination, and direct Coombs test. 4 ml were transferred to plain tube clot activator for the serum analysis. Serum was separated by centrifugation at 4,000 revolutions per minute for 5 minutes, following which the biochemical analysis was done. Now the following tests were carried out. Complete blood counts were generated through Sysmex KX21 automated hemoglobin analyzer after adequate quality control and necessary calibration were required. Peripheral blood smears were obtained by the finger prick method, and after that they were stained by Leishman stain. Reticulocytes were counted and expressed as percentage after supravital staining by brilliant crescile blue stain. Direct Coombs test was carried out using the anti-human globulin Coombs reagent. Serum LDH levels and serum bilirubin direct and indirect were measured on Selectra XL. Bone marrow examination was done, and anti-neutrophil cytoplasmic antibody test was done to rule out autoimmune agranulocytopenia. In addition, to exclude the other important diseases, autoimmune diseases, following screening tests were done: RA factor, ANA, thyroid function test, thyroid peroxidase antibody test, HbA1c test, and all the results were recorded on the performer. Now, coming to the diagnostic criteria. Based on the laboratory test, autoimmune hemolytic anemia was diagnosed as positive Coombs test and any other of the two signs of hemolysis, which include increased LDH, reticulocytes, and bilirubin. Similarly, ITP was diagnosed as a diagnosis of exclusion. It was diagnosed as presence of thrombocytopenia with presence of normal or increased number of megakaryocytes in the bone marrow without previous chemotherapy, splenomegaly, or other autoimmune diseases. Pure red cell aplasia was diagnosed as isolated absolute reticulocytopenia with complete absence of erythroid precursors in the bone marrow. Autoimmune granulocytopenia was diagnosed as absence of myeloid precursors in the bone marrow with positive anti-neutrophil cytoplasmic antibodies and exclusion of other autoimmune diseases. The data was analyzed by a statistical package for social sciences, SPSS 23. For qualitative variables, frequency and percentage were calculated, and for quantitative variable, mean and standard deviation was calculated. A total of 64 patients were included in our study. The mean age of patients was 65 years. Coming to the gender distribution of patients, 82.8% were males and 17.1% were females. Now coming to frequency of autoimmune hemolytic anemia and immune thrombocytopenic purpura, 5 out of 64, 7.8% were positive for autoimmune hemolytic anemia, and 2 by 64, 3.1% were positive for immune thrombocytopenic purpura in the CLL patients. Now coming to the frequency of stage of disease according to the Rye classification, in the stage 1, 8 patients were there, in stage 2, 7 patients were there, in stage 3, 20 patients were there, and in stage 4, 29 patients were there. This is the mean and standard deviation of the quantitative variables used in our study. Now coming to the frequency of the Coombs test, it was negative in 87% patients, it was 1 plus positive in 6% patients, it was 2 plus positive in 5% patients, and it was 3 plus positive in 2% patients. Now coming to the discussion, our results show that the frequency of autoimmune cytopenias is comparable to the international studies. As for the autoimmune hemolytic anemia, our frequency of 7.8% is comparable to a study by Monaro et al., which shows that the frequency of autoimmune hemolytic anemia is 7%. Our patients who developed autoimmune hemolytic anemia were mostly male, 80%, and both the patients who developed immune thrombocytopenic purpura were also male. All the patients who developed these autoimmune complications were above 50 years of age and in stage 3 and 4. Hence, our results are comparable to the international data, which shows the association of CLL with male sex, high lymphocyte count, and advanced disease. Autoimmune granulocytopenia and pure red cell aplasia have rarely been reported in chronic lymphocytic leukemia. In a study which was conducted by Mayo Clinic, less than 0.5% of patients presented with pure red cell aplasia or autoimmune granulocytopenia. Similarly, in a study conducted in 2009, none of the patients developed autoimmune granulocytopenia or pure red cell aplasia. Similarly, in our study, none of the patients presented with these complications. So, although Rye and Bennett's system of classification exists in staging the CLL, and they take in account the cytopenias, but they do not provide the information regarding the cause of cytopenias. This study helped in distinguishing autoimmune cytopenias from cytopenias due to bone marrow infiltration, as management of both these types of cytopenias is fundamentally different from each other. British Society of Haematology in 2008 published the following guidelines. It says that in patients with otherwise asymptomatic CLL that does not require therapy and co-current autoimmune cytopenias exist, treatment should target the autoimmune complications. Where autoimmune cytopenias is a dominant clinical feature, initial treatment should be corticosteroids, intravenous immunoglobulins, or rituximab. For autoimmune cytopenias triggered by CLL-directed therapy, the CLL treatment should be halted and immunosuppression therapy should be commenced. CLL-directed therapy should only be initiated if the dominant clinical feature is CLL, or if the autoimmune cytopenias fail to respond to the immunosuppressive therapy. So coming to the conclusion, autoimmune hemolytic anemia and immune thrombocytopenic purpura are the most common causes of immune cytopenias in chronic lymphocytic leukemia. They should always be scanned by a laboratory test, as their management is different from other complications that occur due to bone marrow infiltration in CLL. We recommend that CLL patients should undergo a diagnostic flowchart for presence of autoimmune hemolytic anemia and immune thrombocytopenic purpura. Documenting and planning adequate therapeutic management of these complications will lead to a better outcome and improved quality of life in these patients. I thank you all for patiently listening.
So we are going to take questions in the end, so I would request you to stay back. If we have any, we will direct them to you. Thank you, Dr. Haider, for that presentation.
Thank you
So
very
that
much.
wraps up the free paper presentation. And now we move on to the invited talks in this session. And I'm pleased to invite Dr. Mohammad Usman, Sheikh, who is a associate professor in hematology and the section head of clinical hematology in the Department of Oncology here at AKU at Arkan University. And Dr. Usman today is going to talk on risk stratification in high-grade lymphomas and its clinical application.
Thank you very much, Natasha, for the introduction. The topic which was assigned to me is the risk stratification in high-grade lymphoma. I have no conflict of interest, and my talk is actually divided into 5 parts. First is the overview of cancer status in Pakistan. The second aspect is the lymphomas in Pakistan. Then what are the historical, what is the historical perspective of risk stratification? And as we all know, among lymphomas, diffuse large B-cell lymphoma is the commonest one. So my main focus on the risk stratification of this particular lymphoma, followed by a little bit discussion about mantle, PTCL, Burkitt and others. So this is what I noticed when I searched the literature. These are the WHO figures. There is an agency with the name of Globocon, which actually collect data about cancer from all over the world. And this is the data which is provided by Pakistan to this agency. And this actually fairly depicts the overall picture or scenario of cancer in our part of the world. It actually includes 18 centers which are federally run. These are all, we know, Kiran, Noori, Sinar and others. Similarly, Shaukat Khanam data also included in it. So it showed that the total number of approximately 173,000 cases were diagnosed in 2018. And there is, we can see that 81 out of those 173,000, 81,000 were male and 92,000 were female respectively. And the commonest malignancy in the male, again, due to cigarette and gutka and pan, oral cavity and lip cancer. And in female, as we all know, the top of the list, approximately 31% of the total cancer was the breast cancer. Now come to hematological malignancy, overall picture. So the top 5 cancers, fortunately, doesn't include any hematological one except leukemias, which is the 5th one among males. And overall, it is also 5th in the listing. And when I look at the hematological malignancies, there are out of those 173,000, 16,000, which is approximately 9% of the total, were the hematological malignancy. And out of those, one can easily notice approximately 6,000 were non-Hodgkin lymphomas. Now, this is AKU data of only of 1 year, and that can show that the total, according to the frequency, lymphomas are at number 10, and the total number in the 2017, total lymphoma which were reported in our institute was 223. And out of those 223, 78 were Hodgkin, while the remaining were non-Hodgkin. And one can easily notice that approximately 70% out of those B-cell lymphomas were the diffuse large B-cell lymphoma. Very few Burkitt, especially in the mostly in the pediatric age group, just 1 to 2 in the adult, followed by follicular lymphoma. At one time, till in 90s, in the western part of the world, the follicular lymphoma was the commonest one. However, now all over the world, DLB cell is the commonest one. But in the past, follicular lymphoma was the second commonest according to WHO frequency list. However, in our part of the world, especially in the Asia, follicular lymphoma as compared to diffuse large B-cell lymphoma is quite uncommon. And you can see mental and marginal are again very rare. So similarly, Shaukat Khan reported approximately 60% cases of DLB cell in their data. Now, what is the historical perspective of risk stratification? In 1996, Rappaport described lymphomas, and they categorize these lymphoma only on the basis of two things. One is the cell size, and the other one is the growth pattern. And this, according to the cell size, at that time there were only two cells were recognized. One is the small one, that is the lymphocyte, and the large one, which they name as a lymphocyte, histiocyte. Followed by Rappaport observed the overall growth pattern of the lymph node, and there are two major patterns. One is the nodular, the other one is the diffuse. So on these ground, they classify these lymphoma either small lymphomas, diffuse or nodular one, or large lymphoma with diffuse or nodular one. Now in 1982, from clinical perspective, another classification was introduced, and that divide on the basis of 5-year survival. So those patients who have a highest survival, that is a 5-year survival of more than 50 to 70%, they categorize as low risk. Similarly, in between low and high, there is an intermediate category that is approximately 35 to 45%, and those who survive approximately 30% 5-year survival, that was categorized as a high risk. And that is again mainly based on the morphological feature of the cells. So those lymphomas have a small cell, they are categorized in the small lymphocytic and follicular category, whereas in the high grade lymphomas, such as they describe as immunoblastic or Burkitt-like because of the starry sky appearance. So this is basically based on morphological as well as outcome based. Then comes the real classification in 1994, which not only based on morphology, but there was a rapid advancement in the immunological and genetic characteristics of this lymphoma. So for practical purpose, we can divide real classification into three broad categories. One is the indolent or low risk, second one is the aggressive, and the third category is belong to very aggressive lymphomas. And among these, one can easily note that in the aggressive category, in the B cell, there are DLB cell and mantle cell, whereas in the T cell, there are peripheral T cell lymphoma. However, there is one category of low-grade lymphoma which can categorize as an aggressive one, is the follicular grade 3 lymphoma, particularly follicular grade 3B. And among the very aggressive, there is only one lymphoma, which is Burkitt. So we all know, so our main focus on DLBCL, we all know that DLBCL is a curative disease or curative malignancy, and where intent should be to eradicate the disease. And now still the standard is CHOP with rituximab, 60 to 65% 5-year survival rate. However, still there are 30 to 40% relapse or refractory disease. Now, whenever, not only from lymphoma perspective, whenever you see a patient in clinics or during your training, we have to risk stratify a patient for whatever disease. Although I particularly focus on DLBCL, so one is disease-related factor, the other one is the patient-related patient characteristic. As far as disease-related features are concerned, especially with regard to diffuse large B-cell lymphoma, we need to know the anatomic site. We need to know from the history there is a de novo lymphoma, DLBCL, or is a transform from some other low-grade lymphomas. We must know about the histology, like T-cell with B-cell lymphoma. Rare, but once in a while, one can see, or in practice, there are CD20 negative diffuse large B-cell lymphoma within a special category of plasmablastic and L positive. We must know before treatment what is the cell of origin, like activated B cell versus germinal center. Similarly, from immunohistochemistry, or by FISH analysis, we can look into double hit or expressor characteristic. Similarly, it is very important to know about the early stage versus advanced stage, followed by risk scoring. And for the DLBCL, it is still standard to do the ITI scoring. Now, from patient perspective, it is very important about the age. Our average age is 66 years, as compared to West, where the average age is now more than 85, 86 years. So it is approximately 20 years less in our part of the world. So this is a very important factor whenever deciding. So our 60 years now equivalent to 80 years of any patient in the West from all perspective. Similarly, performance status is very important. Say, for example, if patient is coming on wheelchair or on the stretcher, then you should be high alert. How far you can go to treat this patient. Comorbidities, we all know, we must know if patient has diabetes, hypertension or something. Status of heart, it is essential practice to check for the ejection fraction. Similarly, renal and liver status are important. If they are deranged, then you are in trouble and you need to start some sort of second line therapy instead of standard care. And once there is a compromise, there is always a chance of inferior outcome. In our part of the world, especially financial status, each and every patient we have to individualize. Why? Because even we all know in our practice, sometimes patient, it is unimaginative in Western part of the world to give treatment without rituximab in a patient with DLBCL. But here in our part of the world, we have to individualize. Sometimes patients have no money except for just or very little money just for, say, for example, excluding rituximab, just CHOP. Although overall in journal, only 10% survival advantage, which is added with R. Say, for example, a patient of any stage, if you add rituximab, you can get an advantage of 10% overall survival. So sometimes you have to give only CHOP instead of R-CHOP. So because out of pocket, there is no insurance coverage in our part of the world for most patients. Now, DLBCL is a very heterogeneous disease, as I already mentioned. So as I mentioned, that you need to know first the anatomic side. Say, for example, rare but primary CNS lymphoma we have seen in practice, followed by primary mediastinal lymphoma. Then rarely we have seen just primary breast, testes, thyroid, adrenal, paranasal and paraspinal involvement, primary gastric, and very rarely intravascular. So in our we need to stratify CNS involvement also. From different studies, we come to know that approximately 10 to 20% risk of CNS relapse in DLBCL, especially if patient have breast, testes, thyroid, adrenal, paranasal, paraspinal, skin mediastinal or double hit status, or with HIV, we need to consider some sort of prophylaxis. The other characteristic, there are many. The most famous one is the CNS IPA scoring of NCCN. So stage 4 disease, high LDH, age more than 60, all these need to consider before start treatment. There is no standard of care for patient. There is especially for prophylaxis. However, we need to consider some institutional based guidelines. We are very commonly practice at least 4 ITs in these patients. However, some institute give high dose methotrexate 2 to 3 cycles after the completion of 6 doses of R-CHOP. Now, as far as primary lymphoma is concerned, just one slide. It is very uncommon. Less than 1% of DLBCL prognosis remains poor. Overall survival has improved with new chemo and radiotherapy. And we all know RMPV, those who are treating this patient, followed by high-dose cytotoxic therapy with autologous stem cell rescue. Excellent disease control and overall survival, 2-year progression-free, approximately 79% were observed with an acceptable toxicity and minimal neurotoxicity. Secondary CNS involvement carries very poor prognosis. The median survival is just 3 months. What does secondary mean? That is either either concomitant or recurrence of CNS involvement after completion of systemic therapy. So we need to consider only 3 months survival with this median survival. Primary mediastinal, yes, is approximately 10% of the total DLBCL, and results are quite good with R-epoch, and some studies it reaches up to 93 to 97% of overall survival and event-free survival. And this without radiation, this is very important. Previously, what people do or physicians do, they give R-CHOP followed by radiation to mediastinum. However, in this study, and this is now the standard of care for primary mediastinal B-cell lymphoma. So anatomic side is important. Now, from histological perspective, T-cell rich B-cell, DLBCL, which is approximately 10% of the total DLBCL, and this is a fancy name, T-cell rich histiocytic B-cell lymphoma. However, treatment remains the rituximab with CHOP, and outcome is same. So we can consider the same. As I mentioned, very rarely there is a plasma cell component in this lymphoma, which are CD20 negative, CD138 positive. There's a large study of 590 cases. There are also HIV association. There is a poor prognosis. Overall prognosis just 3-year overall survival just of 25%. Bortezomib in combination with dose-adjusted EPOC induced remission in patient with lymphoma with a 2-year overall survival of 50%. So R-CHOP is not effective. We can consider dose-adjusted EPOC. Important to note, there is no role of rituximab in these cases, followed by and with addition of bortezomib. L positive, CD20 negative, very rare, only case reports. It was first reported in 1997. I have seen just one case in my life. 5-year old survival was 34% and the median survival was 1.83%. It was treatment, the treatment is on the same line with dose adjusted EPOC plus minus bortezomib. It's a well-established term. There's a transformed lymphoma. And the commonest example is one that is follicular lymphoma transformed into DLBCL. Whenever a patient with a follicular lymphoma presented with a rapidly enlarging nodes, with these symptoms and increasing LDH, one should always consider in the differential that there is a transformation from low grade to high grade. It is approximately 40 to 50% follicular lymphoma patient develop this DLBCL with a 3% incidence per year. Historically, follicular lymphoma that's transformed into diffuse large B-cell lymphoma portend a poor prognosis with a median overall survival of just 1 to 2 years. The other is a richest transformation. We all know from chronic lymphocytic leukemia or from SLL into an aggressive lymphoma, which is most of the time is DLBCL, approximately noted in 2 to 10% of these patients. 80% of DLBCL cases in patients with CLL are clonally related to underlying CLL, like TP53 or 11q. These are the underlying cytogenetic abnormalities in these patients with DLBCL. And again, median survival is very poor. Now come to cell of origin thing. We all know, because there are many postgraduate students in our participant, so we all know that the nucleus is actually consists of chromosomes. And now these chromosomes are actually the cluster of genes. And in turn, there are approximately 20 to 25,000 human genes, and these genes are made up of DNA, which are actually again are the molecules with the name of adenine, thymine, guanine, and cytosine. Now, what is gene expression profiling? This is actually the measurement of activity of thousands of genes at once to create a global picture of cellular function. Now, these profiles can show that how the cell react to a particular treatment and prognosis. Say, for example, genes highly expressed in activated B-cell DLBCL separate out from the one which are germinal center base. So, on the basis of this gene expression profiling, we can segregate these broad categories, two broad categories of DLBCL, and that is one is ABC, or that the other category is GCB. GCB is more common than ABC, or approximately 60-40 ratio, but overall these are the two broad categories. Now, gene expression profiling, although is the gold standard for the determination of cell of origin, but it requires expertise, it requires fresh tissue, and is not routinely available even in the Western world. So given their ease of use, ISC algorithm, that is immunohistochemistry algorithm, there are many, but HANS algorithm is the one of the most commonly used one, which concordance with a concordance rate of gene expression profiling is approximately more than 80%. And that is, we all know, if CD10 positive, this is automatically germinal center. In case it's negative, then you need to do the BCL6 followed by 1-1, and we can further categorize on the basis of ISC. And there is no doubt, out of this study revealed, out of 344 patients treated with R-CHOP, the outcome at 5 years is inferior for activated B cell, which is 56% as compared to 78% in GCB type. And people tried many things in activated B cell type activated B cell or ABC type DLBCL. However, nothing works. Some people add lenalidomide, ibrutinib, and bortezomib, but the outcome is poor. So still we prefer to give R-CHOP. There is no other option. Now, this category, although rare, up to 8% of the total, that is high-grade B-cell lymphoma with c-MYC positivity as well as BCL2 or BCL6 positivity. Just 8% of the total. Actually, it requires, to document it, we need MYC positivity along with BCL2 or B6 on fish, not on ISC. If these c-MYC, BCL2 or BCL6 positivity noted on immunohistochemistry, then we tell that either is a double expressor or triple expressor. So overall, just up to 8%, and there is no standard of care at present because they behave poorly with R-CHOP. At present, people use dose-adjusted R-CHOP with some survival advantage, and I have seen few studies, there is no survival advantage with autologous transplant. So the second category, as I mentioned, up to 35% of DLBCL are actually double expressors rather than double hit. That is, we noted it on immunohistochemistry. Again, somehow there is an inferior result when compared to negative ISC. Still, R-CHOP is recommended. And we have noticed in this study, which was published in Journal of Clinical Oncology, that patient with de novo without c-MYC or BCL2 BCL6 negativity fare much better as compared to those who have double hit or double expressor characteristics. Now, there is a very important message in this limited disease. If most of the time DLBCL is a disseminated disease, but even not only in high-grade lymphoma, my one message to all the treating physician is that if anyone come across with early stage even in low-grade lymphoma, go for a kill. Go for a kill, go for a cure in limited stage, stage 1 or stage 2, non-bulky. So, in one of the study in ASH, showed that 89% of the patient with stage 1 to DLBCL maintained excellent outcome after 4 cycles of R-CHOP. With PET-directed therapy, only 11% of patients with an interim PET positive can require radiation therapy. So even without radiation, only 4 cycles of CHOP can produce excellent remission rate up to 90%. The another important thing, in the limited stage disease, in the limited stage DLBCL, the bad prognostic characteristic of double hit or double expressor shows no association. And so even with early stage, if the patient showed double expressor or double hit, there is no need to worry. And there is again approximately 85% to 90% progression-free survival and overall survival. So this is the second important message, and there is no need for intensified chemotherapy. Simple R-CHOP is enough. Now come to the last for the DLBCL. We all know, and this is still stand good. This is one of the one of the largest study probably of DLBCL, which was published in NA GM in 1993, of 2031 patient, and that study consider multiple variables including tumor stage, serum LDH, performance status, and number of extranodal disease, and that categorize these four categories: low, intermediate, high, and high, intermediate, and high. And we all know, and we need to document it IPI score before starting treatment. Till to date, as I mentioned, why CHOP? Because in the past, yes, people tried in that particular trial that against CHOP, there were many fancy type of combination therapy was given, but again, CHOP stand out with very less mortality and almost equivalent survival rate. Now, just 2 or 3 slides. One is for mantle cell lymphoma. Overall, there is 6% of out of overall there is a 6% incidence of mantle cell lymphoma world over. But in Pakistan, we have no data. Probably less than 2% have having lymphoma of this category. Median age, most of the time elderly patient with a male preponderance. Early stage is very rare, but again, if you find early stage, go for a kill. As I mentioned, there is a very good progression-free and overall fiber survival reported up to 68%. GI workup is important even for early stage. There are GI symptoms. Typically, advanced stage and B symptom usually less frequent, 90% extranodal involvement. And this slide mentioned that among all lymphomas, common lymphomas, mantle cell carries poor prognosis. Now, IPI score is very useful in other lymphoma also. This is the simplified mantle cell IPI, and they use basically performance status, age, LDH, and WBC. With sensitive assays, we can pick up in approximately 90% of these patients, we can pick mantle cells, mantle lymphoid cell with of mantle cell origin in blood and bone marrow. So that's why they include this WBC count. So again, on the basis of that, we can classify low risk, intermediate, and high risk. Can we consider wait and watch policy in this group of patients? Only if Chi67 is less than 30, lymph node size is less than 3 centimeter, normal LDH with and normal beta 2 microglobulin, lack of B symptoms. If there is classic histology and low risk on MIPI, then you can wait and watch in these patients. And there is definite survival advantage with wait and watch. This is important in a low grade category. No standard of care still till to date for mantle cell. No curative therapy. Median overall survival just 3 to 5 years. Subset of MCL, as I mentioned, we can wait and watch, still very poor outcome. Peripheral T cell lymphomas, there are 27 different types of PT cell are described in the 2016 WHO classification, 5 to 10% of all NHLs. It comprises 15 to 20% of all aggressive lymphoma. The important categories which we know, which we have seen in our practice are PTCL not otherwise specified. Rarely we see anaplastic with both L positive and negative. IPI is still in use, early stage versus later stage. Again, consider early stage. If there is again early stage, then go for a kill, as I already mentioned. Go and hit hard for early stage to cure these patients. L positive carries good prognosis. However, it is also important in the ALK negative PTCLs or ALCL to look for DUPS22 mutation, which is noted in approximately 30% of this patient. Even having a ALK negative status, they carries very good prognosis, more than 70%. Now, CD30 positivity is very important. If it is more than 10% in any peripheral T cell lymphoma, you can consider the option of brentuximab. Although cost is an issue, but one should consider it whenever there is a more than 10% positive in all type of. This is probably my second last slide. So the Burkitt lymphoma is mostly seen in our part of the world in the pediatric age group. Now, Dr. Zahra, our pediatric oncologist, in one study revealed that out of 51 non-Hodgkin lymphomas in pediatric age group, 28 were having Burkitt lymphoma, which is approximately 55% of the total lymphomas. So this is the commonest lymphoma, Burkitt lymphoma in our part. Although we are not in the endemic area, most of the presenting feature is actually with the abdominal mass, which surgeon open it and on the gross and further examination, that mass is turned out to be either Burkitt. The second common is the DLBCL. It is also HIV related, probably the most aggressive tumor with the CNS involvement, less than 24-hour doubling time. So we can just consider how aggressive is it. In pediatric, staging system of St. Jude's. However, in adult, we have seen few patients with stage 4 with marrow involvement. I've seen extremely dismal outcome. I haven't seen a single survival in adult with this stage 4 disease. Yes, early stage 1 or 2, yes, we have seen quite a good survival, but a stage 4 disease with marrow involvement, extremely dismal outcome. Last slide. There is a category of follicular, actually follicular lymphoma divided into 3 grades. Grade 1 and 2 lumped together as a low grade. Grade 3 further subdivided into grade 3A and 3B. 3B is rare, but it is aggressive and it is usually treated as diffuse large B-cell lymphoma. Management of grade 3A is controversial. Some people treat it as a low grade follicular lymphoma, and some people treat it as otherwise as a DLBCL. However, more than 50% diffuse component carries poor prognosis even in 3A. So in conclusion, my last slide, DLBCL is the most common type of lymphoma. Whenever a patient came with a diagnosis of DLBCL, you need to know about the site of origin, cell of origin, international prognostic index, CNS IPI, hit status, transform 1, and overall patient characteristics, as I mentioned. Early stage versus advanced stage, because in the early stage, the treatment is quite easy as compared to advanced stage. Mantle cell lymphoma, on the other hand, most of the time is a disseminated disease and usually incurable. Peripheral T-cell lymphoma is a rare lymphoma in our part of the world with limited experience, usually high risk and poor outcome. Burkitt lymphoma, mainly noted in pediatric, very few in adult with dismal outcome in stage 3 and 4. Thank you.
Thank you very much, Dr. Usman, for that update on aggressive lymphomas. There are a couple of questions which I will take in the end. We now move on to our next presenter, Dr. Khurram Bilal Tariq, who is a hematologist and a medical oncologist, and also the director of the oncology service line at St. John's Cancer Center. Dr. Khurram is also our international coordinator for Pakistan Society of Hematology. And Dr. Khurram today is going to talk on role of CAR T cells in hematological malignancies. Dr. Khurram, over to you.
My name is Khurram Bilal Tariq, and thank you so much for inviting me again. I'm presenting to you from the city of Boone. It's pretty cold, -19 the other day. And, this is what it looked like right outside where I live on the right-hand side. So we'll be talking about CAR T cell therapy and its emerging role in hematologic malignancies. Just a brief overview. I realized my initial presentation was 130 slides, but I had to summarize everything in a 25-minute presentation. So background, CAR T cell has really garnered a lot of interest over the years. In ASH 2019, we had about 540 abstracts. This, of course, due to pandemic, came down to 255 in 2020. The field of adoptive cellular therapy is not new. It began in the 50s with the discovery of HLA and interferon, then with the identification of T cells and B cells in the 60s, and then with the development of CAR concept in the 1980s, followed by first generation CAR T in 1993, followed by second generation CD20 and CD19 constructs in the 2000s. So this is an overview of the process itself. So you have leukapheresis. The patient comes in, they're leukapheresed. T cells are isolated and activated, and then they're engineered with CAR gene. Usually a viral vector is used. And then here is what a second generation CAR T looks like. I'll spend just a little bit more time on this because that will build on my presentation. So you have two major parts. We'll just simplify it. Two major parts, the extracellular right here. So this is the receptor that targets a particular antigen. And this antigen is found on the tumor itself. If you're targeting B-cell malignancies, CD19 is your go-to antigen in 2021. For multiple myeloma, BCMA, so on and so forth. Then you have the intracellular domain. This is the signaling domain. There are two parts to it. The CD3 zeta, which is the primary signaling domain. This is present in first generation and throughout all the subsequent generations. Then you have co-stimulatory domain. This was added with the second generation and with the future generations. So in co-stimulatory domains, you have a CD28 or 41BB, and it has implications in apoptosis and proliferation, overall survival, so on and so forth. Once this is done, these CAR T cells are expanded and they're infused back into the patient. This entire process, and then the magic happens, right? This entire process may take 3 to 4 weeks, and a lot of patients cannot wait 3 to 4 weeks. So a lot of time bridging therapy or salvage therapy is applied. So how do we choose, or what's important in picking the right antigen on a particular tumor? There are some characteristics, I'll go over them. So, it should be specific to the tumor cells, right? To prevent the off-target effect. That's one. It should be expressed on the surface. And that's the problem with AML. In field of AML that I will discuss, we are lagging behind because we have not been able to identify a lot of surface antigens that we can target. Then this antigen should be required by tumor for its survival. Because if the antigen is there, but it's not playing an integral role in the functioning of the tumor, then it's useless. So over the last several years, the interest in CD19 CAR T cell construct has overshadowed all the other abstracts. So on the right-hand side, you can see 146 abstracts versus just 26. So by far the most studied area. Then after the CD19, you have a BCMA, which is multiple myeloma, as I explained earlier. CD19, since it's very important, and in the United States, most of the FDA-approved CAR T cell therapies are in CD19. Let's just talk about it for just a brief moment. So this one is chosen because it's, again, restricted to B cells, B tumor cells as well, and also follicular dendritic cells. It's expressed on the cell surface. And then the important thing is that it's not expressed on stem cells. So you would not see stem cell aplasia, which may not be compatible with life. However, the side effect is that you will see B cell aplasia, which is compatible with life. So this is the first paper in 2003 in which Raji infected mouse. So Raji is Burkitt's lymphoma. Infected mice were treated with first generation CAR T cell. And it showed CR in as much as 100% of these mice. But what we noticed is that the duration of response was very short-lived. So then, the second paper came out whereby the NALM-6 is basically ALL. So now the ALL infected mice were treated with the CD19 CAR T cell construct. And what we notice is that when we add a co-stimulatory domain, this is the second generation of the co-stimulatory domain, it adds longevity and increases survival. So two important pillars in the field of CAR T cell were established based on these papers. One is that you need both a signaling domain in the intracellular domain, and then a co-stimulatory domain as well, which could be CD28 or 41BB or OX40. In the absence of these co-stimulatory domains, you have T cells becoming unresponsive and apoptose early. So these are the generations of CAR T cell therapy. The first generation CAR T cell, which is obsolete at this point, it only included CD3 zeta. If you look at the intracellular domain, right here, it only included CD3 zeta, did not have a co-stimulatory domain. This co-stimulatory domain was added in subsequent generations. However, this extracellular domain, the antigen binding domain, this is, you can think of it as a receptor for a particular antigen on the tumor cell. It's similar in all the generations. So in the second generation, because of the papers I've shown in other studies, a CD28 or 41BB co-stimulatory domain was added that led to improved proliferation and
Sorry, I missed
translated.
that. Could you say it again, please?
excuse me, and translated in better overall survival in patient population. In the third generation, this is still in the research pipeline. It's not widely available. What the scientists are trying is they're adding both the known the common co-stimulatory domains on the same CAR T cell construct. And then the fourth generation, also known as TRUC, is where the cytokine gene manipulation is being worked into. The idea is to change the microenvironment and help CAR T cell be more effective. This will probably come in handy with our treatment of solid tumors. Again, a slide that summarizes what I just explained. This is again a second generation CAR T cell, because this is where the field is at in 2021. So I thought I'd focus a little bit more on it. So you have the binding domain, CD19 construct, because this is what's been approved by FDA here in the United States. Then in the intracellular domain, you have the original essential signaling domain, the CD3 zeta, TCR. And then you have the co-stimulatory domain right here. It could be CD28, 41BB, or OX40. The two approved products, one of many now, are Exa-cel, Yescarta, and Tisa-cel, Kymria. So the major difference is in the use of the type of co-stimulatory domain. In Exa-cel, it's CD28. In Tisa-cel, it's 41BB. So the role in hematologic malignancies, we'll focus on non-Hodgkin's lymphoma, and then we'll move up. So this is a summary slide across non-Hodgkin lymphoma. So you have Exa-cel, Tisa-cel, and brexocaptogene. These are different CAR T cell products, leading to the approval of CAR T cell in diffuse large B-cell lymphoma for the Exa-cel and transformed follicular lymphoma and the types. Then in Tisa-cel, this is a little different in that it's similar in that diffuse large B-cell lymphoma was also approved in the refractory setting, but you also have approval for the pediatric relapsed refractory lymphoma up to the age of 25, and we'll briefly discuss about that in just a second. Brexocaptogene is similar to Exa-cel in that the same co-stimulatory domain is used. The only difference is that the CAR T cells are, the T cells are selected for, and that's how it's different. And it's approved for relapsed refractory mantle cell lymphoma. So diffuse large B-cell lymphoma. Before the era of CAR T cell therapy, SCHOLAR-1 trial was a pooled retrospective analysis of 2 phase 3 trials and 2 observational studies. And what it showed is that in the refractory setting, the chance of any response is 1 in 4, right? 26%. And the chance of a CR is only 7%, which led to the median dismal overall survival of only 6.3 months. Now, in the CAR T cell era, you have several pivotal trials, the ZUMA-1 trial, the Juliet trial, which are both phase 2, and then the Transcend 001 study, which led to the approval of both Exa-cel and Tisa-cel, 2 products that we have discussed earlier. And they showed an overall response rate as high as 82%. Now, this led to an overall survival at 12 months of as much as 60%, 59% at the bottom of the slide. So that's what led to this approval and is moving the field forward. Now, this is an important slide talking about some of the factors that are associated with worse overall survival and progression-free survival in Exa-cel space, but it can be extrapolated to other CAR T cells as well. So high LDH, male gender, and the use of bridging therapy. Bridging therapy just means that within the 3 to 4 weeks where we are waiting for the product to be made, the tumor is so aggressive, you have to try something or the patient is not going to make it. So the patients are already sick, the disease is aggressive, and that just makes sense that these patients will likely have a poor outcome. Then ECOG performance status, poor, 2 and up, also do bad. So this is all common sense for hematologists, oncologists, throughout the world based on the conventional chemotherapy experience, right? But what we also discovered, and this is highlighted in the middle here, is younger people do worse. So patients less than 60 do worse than patients more than 60. And this is against the grain of our experience with conventional chemotherapy. So don't hold CAR T cell therapy back just because someone is old. That's the take-home message. Moving to mantle cell lymphoma and follicular lymphoma in the relapse refractory setting. This is also, so mantle cell lymphoma is an unmet need in the refractory setting, and the 5-year-old survival is pretty dismal. So you have the ZUMA-1 trial. It was a multi-central global study. If you get a chance, read the study design. A massive undertaking. So it was a phase 2 trial where conditioning regimen with flu-cy was used, and brexocaptogene was studied. This trial, the ZUMA-2 trial, led to a progression-free survival of 60% and flattening of the curve. The flattening of the curve is the most important part in this slide, because a lot of these trials, as we'll see, the problem is with the duration of response and the relapse. So follicular lymphoma, from experience, we know when they do well, they do really well, but then the relapse setting, in the transformed follicular lymphoma setting, there is an unmet need because the survival is poor. So ZUMA-5 trial looked at axi-cell, studying relapsed refractory follicular lymphoma and marginal zone lymphoma. And it led to an overall survival, overall response rate, of 93%, an improvement in both progression-free survival and overall survival across follicular lymphoma and marginal zone lymphoma. CLL, just like follicular lymphoma, when they do well, but when they're refractory, they don't fare as well, especially in the BTK inhibitor and venetoclax refractory space. So the phase 1 with phase 2 trial, the Transcend 004 study, studied lisocabtagene and showed an improvement in overall response rate in excess of 80, and a great MRD negativity both in blood and bone marrow. So these are some of the future clinical trials. Top 3 are phase 3 studies where we are moving, and you will see this trend, moving CAR T cell up the chain. So here we are studying it in second line in the relapse refractory space. Myeloma space is very crowded. A lot of therapies have been approved over the decades, most recent one being the belantamab. And that's important because it's an antibody drug conjugate for BCMA. BCMA is important because that's what we will be talking about in CAR T cell space. So in 2022, as you know, much better than I do, that the standard of care is a triplet. In the United States, we use VRD. Trials like the Griffin trial has shown how DARA plus the VRD space is a very enticing option. But patients who are refractory to CD38 antibody, like DARA, they don't do so well. So in penta-refractory patients, for example, patients who are refractory to CD38, plus 2 PIs and 2 IMiDs, the median overall survival is only 5.6 months. And so that's an area of unmet need. And these are the patients that are being studied. So BCMA was chosen as a target. Why was it chosen? Going back to the previous slide, because it's very specific to myeloma cells. And then it's involved in a major function of the tumor, which is maturation and differentiation. The expression increases as the disease progresses from MGUS to advanced myeloma. So the BCM space is very crowded. You have antibody drug conjugates like the belantamab that I discussed earlier. Then you have BiTE cell treatments, bispecific T cell engagers, multiple options being studied. And then you have CAR T cell therapies, at least 6 products being studied in that space. This is what a CAR T cell construct looks like. On the right here, you have the receptor going after the BCMA. So this is the CAR T cell extracellular domain. This is what it looks like. And then you have the 4-1BB co-stimulated domain. And then our old friend CD3 zeta, the initial signaling domain is also present as it is throughout this space. So across clinical trials, whether it's the KARMA trial, the EVOLVE trial, or the CARTITUDE trial, these are landmark trials in the myeloma space. The baseline characteristics included patients who were heavily treated, 6 or more lines of treatment in this space. And they have a whole bunch of disease in their bone marrow, poor cytogenetics, But the efficacy was very good. Overall response was in excess of 70, reaching as much as 100% with the J&J product with CARTITUDE-1. The problem, of course, the devil is in the detail. The problem was in the duration of response. Like with all the other tumors, the response is short-lived. Safety across clinical trials, these patients with BCMA do fairly well in terms of CRS, in terms of neurotoxicity. I think what has happened is that over the years, we have become better with treating the side effects, whether it's with steroids, tocilizumab, or so forth. These are some of the other treatment options in this domain. In several phase 3 clinical trials that are studying CAR T-cell in a randomized fashion with the standard triplet therapy. So a lot in the pipeline. Looking at future for myeloma, you have a BCMA as a promising target, great response, acceptable toxicity. However, the problem is with relapse and resistance. The hope is that moving it up the chain will improve duration of response. ALL, again, across trial, there are 2 different studies here. Across trial, the overall survival at 5 years in the refractory setting is only 7%. And so CAR T-cell has studied this and has been approved based on the Ileana trial, which was a phase 2 trial looking at T-cell cell. Then you have Memorial Sloan group looking at JCAR and then Zuma-3. Unfortunately, the Memorial group had to halt its trial because of 5 cases of fatal neurotoxicity. But the Ileana trial group did very well, median overall survival of 19.1%. And so it's approved in the pediatric population and also in individuals up to the age of 25. So this is ALL space across adults and pediatric population across trials. Very good slide, puts it all together. What I want to share here is that CR is exceptional. In most of these trials, it's in excess of 80%, lowest being 70, and then up to 89. But the problem is in the details, right? The relapse is close to 40%. And what we realize is that across trials, this is the natural course. So you have an initial drop like here, and then you have flattening of the curve, which is good news. The idea would be to move this flattened curve up to decrease this drop here, because this drop here represents refractory disease or relapse disease, which will then translate into overall survival. So what we notice is that about 40% of these patients relapse, and about 25%, right, like here across studies, has a CD19 negative disease. There are multiple theories as to what that might happen. One of them is that there is a loss of exon 2, which results in truncated CD19. So it's present, but it's truncated. It's not detected, picked up on immunostains or antibodies, and does not trigger CAR T-cell killing. But the persistence of B-cell aplasia is a sign that it's present and it's truncated. So, this is an example of when things look good on paper but don't work. So you have a bispecific that was created, adding both a CD19, which is the case that we have studied so far, and a CD22 construct, right? The idea was to use CD22 as a target if there is a relapse with the CD19 disease. Showed good response, but again, the relapse was 33%, and about 42%, 3 out of 7 of these patients also had CD19 negative relapse. So nothing to write home about. Then you have phase 3 trial undergoing, which is the Oberon trial, looking at overall survival, something to keep an eye on. AML space, as I alluded to earlier, unfortunately, we have not been able to find any unique targets on the cell surface. There are several targets being looked at. An intriguing thing that happened in Israel was that they realized that the AML clones that have the translocation 821, they express CD19 antigen. So 2 of these cells were treated with CAR T-cell with the CD19 construct, but there are only 2. They showed some response. We don't know the long-term safety and efficacy. So the future involves allogeneic CAR T-cell and CAR T-cell with immune checkpoint inhibitor. I have not discussed allogeneic, but because that's beyond the scope of this limited presentation and an overview. So these are some of the other targets, and the CD123, 33, and LEY. And as you can see on the right, There are some abstract, but it's just very limited. But the space itself is very crowded, a lot more to come. There are a whole bunch of, CAR T cell targets that are being studied, and a whole bunch of other antibodies in this space. So this is a summary slide. So you have, in the United States, CD19 construct that are approved by the FDA, brexacaptogene for relapsed refractory mantle cell lymphoma, axicell for relapsed refractory diffuse large B-cell lymphoma, primary mediastinal lymphoma, and then you have Tisa-cell, not just in relapsed refractory large B-cell lymphoma, but also, and of course, transformed follicular lymphoma, and also in the ALL setting up to the age of 25. I'll be remiss if I did not discuss just briefly toxicities in 2 slides. So across clinical trials, across hematologic malignancies, we have realized that the 2 major toxicities that affect morbidity, mortality include the cytokine release syndrome, which is instigated by IL-6, and the neurotoxicity. And that's a major impediment to overall survival. Other toxicities include B-cell aplasia causing cytopenias, immunosuppression, and this entity called the macrophage activation like syndrome. With lack of time, I won't go into details, but these are compatible with life, okay? CRS and neurotoxicity may not be, so it's important that we treat them appropriately. And over the years, we have learned to treat them with tocilizumab, which is an IL-6 blocker, just like cetuximab. And so we have moved it up in earlier grades. As soon as you see a hint of hypotension, throw toci in there. Neurotoxicity, we don't know the mechanism, but they're treated with steroids. And then you have this other entity, which happens in real life, whereby the patient will come in with high fevers, hypotension from CRS, and they become altered as well. So you don't know whether it's neurotoxicity or just CRS by itself. And so most of these patients are treated with both toci and steroids. This was my last slide. And I thank you for your patience. These are some members of my team, and they wanted to say hello as well. And we promise we're all smiling behind these masks. So thank you so much for your time. And I'm available for any questions that you guys might have. Thank you.
Thank you very much, Dr. Khurram, for enlightening us on what's happening in the world of CAR T cells. We have a couple questions, and we will take them when all the presentations are done. We just are moving up towards our last invited talk for this session, which is by Dr. Mohammad Aslam. And Dr. Aslam specializes in medical oncology and works at Saskatchewan Cancer Center in Regina, Canada. Dr. Aslam will talk on rare plasma cell dyscrasias.
Bismillahirrahmanirrahim. Namaduhu nusalli ala Rasulil Kareem. Just to introduce myself, I'm Dr. Aslam from Alan Blair Cancer Center in Regina, Saskatchewan, Canada. I'm a hematologist here, and before that, I worked for several years at King Faisal, a specialist hospital in Jeddah and Riyadh, and before that in Ireland, Dublin and Waterford, and I got my certifications from United Kingdom. So this is just from our beautiful country. I first would like to thank Pakistan Society of Hematology, Dr. Parvez and Dr. Nuzhat, and I'd like to thank Dr. Shahzad and Nasir for the invitation. I'm very grateful. This picture is here to show that staying outside Pakistan, it reminds us of Pakistan every single day, not every single day, but several times every single day. And as they say that, आप पाकिस्तान से निकल गए हैं मगर पाकिस्तान आपसे नहीं निकल सका है. So Alhamdulillah, we are very proud to belong to Pakistan and proud to remember our country and our people. So this presentation, amyloidosis, as you can see here, this is an heterogeneous group of disorders in which proteinaceous fibrils accumulate in certain organs. I just want to put my timer so I don't Don't do it too long. So this is a very difficult disorder. Amyloidosis is a heterogeneous, a variety of presentations, difficult to diagnose, and once you diagnose, there are difficulties in managing those patients. Just to give you an idea, this is a picture of a normal glomerulus. As you can see here, these are the glomerular capillary walls. And this is here, this one is tubular basement membrane, and you can see they're quite similar. This picture here, it shows you from the renal biopsy. This is a glomerular amyloidosis, and you can see this here, the amorphous deposits or nodular amorphous material, and this in the process damages the glomeruli, affects their filtration function, and subsequently causes renal failure. Now this is the bifringent green that you can see in this arrows. This is showing the amyloid deposits here and here and here. So the important thing for amyloidosis is to have accurate diagnosis of the not only of the amyloid but the type of the amyloid, and this is important because of the different treatment modalities, because of the prognosis and all those kinds of issues. The types, the bigger types, as you know, is AL amyloid, which comes from the light chain fragments, and this is caused by plasma cell dyscrasia. The other one is AA amyloidosis, which potentially happens in chronic diseases, inflammation situations, and acute phase reactants, which can form amyloid deposits. There are other forms like dialysis-related, heritable, age-related, organ-specific amyloids, and all those kinds of things. Now, most common is AL amyloidosis, 9 to 14 cases per million persons years in the United States. The challenges are that there is no single blood test or imaging test which is pathognomonic. For example, like in chronic myeloid leukemia, you have Philadelphia chromosome 922, you have it, the diagnosis is done, or 1517 translocation. You have acute promyelocytic leukemia. Once you have it, now it's done. You know, you are sure that you are dealing with CML or AML, or for example, in Burkitt's, there are chromosome 814 abnormalities and very classical starry sky appearance in the pathology and those kinds of things. But here in amyloidosis, there is no single blood test. There is a clinical picture varies. The presentation can be, so many different things. And the signs are highly specific, but they are insensitive. Based on that, you don't always find those signs, and you cannot always conclusively say based on certain. You can have macroglossia, for example. You can have cardiac situations. But again, these are not sensitive markers. Now, from a clinical point of view, if you have a diagnosis of MGUS, a monoclonal gammopathy of undetermined significance, this is a plasma cell dyscrasia kind of situation. This is abnormal gamma globulin produced. So then, you should wonder, or you should consider the possibility of amyloidosis. You should ask direct questions about kidneys, about heart, about looking for the special features, soft tissue deposits, tongue, cardiac, echocardiograph, or different other investigations. Echocardiograph, by the way, I'll come to that ejection fraction is not very always reduced in amyloidosis. So you should have focused physical examination, and you could do certain investigations like NT-proBNP, albuminuria, alkaline phosphatase. So these will guide you towards a diagnosis of amyloidosis. And here you can see that the clinical presentations or signs and symptoms. So number one you see there is heart failure. So the ejection fraction can be preserved, and there can be increased wall thickness often with low voltages in EKG. The next organ is kidneys, causing nephrotic syndrome, proteinuria, progressing to renal failure. There can be cholestatic features and hepatomegaly. There can be resolution of hypertension, because now that the heart function may be affected, then you might actually tilt towards hypotension. There can be peripheral neuropathy and erectile dysfunction. There can be gastrointestinal mobility alterations. And then there can be constitutional symptoms, fever, loss of appetite, weight loss, tiredness, fatigue, these kinds of things. And then there can be soft tissue deposits in the tongue, like macroglossia, and there can be submandibular gland swelling. Just to show you one picture here, that in this patient, there were amyloid deposits below the nose and on the eyelids. So these lesions are waxy and raised, and they show characteristic hemorrhage. So this patient also had severe amyloid arthritis and eventually developed a malignant plasma cell dyscrasia. Now, cardiac manifestations vary, but occasionally you can see rapid clinical deterioration, including sudden cardiac death or MI may happen. And I remember this because some memories are stuck in your mind. So I had one patient who was diagnosed as having amyloid, and she died from complications of that. And then suddenly after that, her husband was diagnosed as cardiac amyloid. And one day, he was waiting in the clinic area, and he collapsed, and he suddenly died from an MI. So these kinds of unfortunate things can happen. There can be rapid clinical deterioration. NT-proBNP and BNP are very useful. Ejection fraction is commonly preserved, and endomyocardial biopsy is the gold standard for diagnosing, but it's an invasive procedure, and there are issues related to any invasive cardiac procedures. As I mentioned, NT-proBNP and BNP, EKG, low voltage can be seen, and you may see arrhythmias, atrial fibrillation, pseudo-infarct pattern, or conduction disturbances. Cardiac MRI is a non-invasive procedure with high sensitivity, 80 to 100%, and 80 to 94% specificity. Now, this is kind of summarizes what I have just discussed with you. So, MGUS-related investigations, then clinical signs and symptoms. And then the question is whether a monoclonal component is present or not. If yes, you go to tissue biopsy, you can do abdominal fat biopsy or bone marrow biopsy, or minor salivary glands, or a biopsy of the organs involved if it is heart or kidney or whatever organ is involved. If you do not have a monoclonal protein, then you can do investigations for non-AL amyloidosis. So you can do, cardiac scintigraphy or DNA testing or those kinds of things. But once you have done that, then you assess for the clonal disease and organ involvement and staging and risk stratification. So you do free light chains, you do bone marrow plasma cells, you do cytogenetics in fish, you do skeletal survey, a serum or urine immunofixation and cardiac investigations and proteinuria and evaluation for comorbidity. So it's a big kind of extensive workup that needs to be done. And with that extensive workup, not only for the purpose of diagnosis, but for your clinical decision making after that, as to the what you are going to do, which direction you are going to take as far as treatment options are concerned. The diagnostic criteria, one is the presence of systemic syndrome, renal, liver, heart, or nerves, or any other organs. Histological documentation of amyloid deposition by Congo red, evidence of monoclonal plasma cell disorder in the serum, urine, or in the bone marrow, and protein typing, as I mentioned before, and this is just in one slide I tried to summarize clinical syndrome, histology, clonality, and protein typing. Now, one very important thing to remember is localized amyloidosis. This can be in the skin, in the urinary tract, in the orbits, colon, airways. Recently, I had one patient who had some pulmonary nodules and had bronchial biopsy, and on the bronchial biopsy, they confirmed that this is amyloidosis, AL amyloidosis, and all his other investigations were negative, monoclonal protein negative, immunofixation serum and urine negative, echocardiograph and pro-BNP and other cardiac investigations negative, no kidneys involvement, liver involvement, nothing. And this patient was diagnosed, I think, in 2014 or 2015. And ever since, he has remained completely symptoms-free, no treatment intervention or anything. So this is important to differentiate systemic amyloidosis, where you would need systemic treatments, versus localized, where you want to just watch it and see whether there is systemic involvement and whether there is any progression, because the best option is not always to treat with chemotherapy and those kinds of things. So you have to be aware of the localized amyloidosis. Now, treatment options, as I mentioned to you before, that before the treatment, you have to have the type, and you have to have the full workup and signs and symptoms, and you have to look at the age of the patient and performance status of the patient. So it has to be a holistic approach. It has to be a full patient approach. Often the treatments are derived from myeloma treatments. Bortezomib is a very important component of the treatments. The treatment options are increasing. In more recent times, we have daratumumab, which is a monoclonal antibody. We have used lenalidomide in some patients. So the treatment options are increasing. You need to look at the individual patient and tailor your treatment according to that. You want to draw a balance, to achieve a balance where you treat the amyloidosis but don't end up in too many complications. And for a physician, this judgment is most important, because if you give the algorithm of treatment to somebody who is not experienced in hematology, he can also look at certain things and he can say, okay, I follow this algorithm and I will use. But this judgment, the physician judgment, is very important. It comes with time. It comes with experience. It comes with studying the subject. It comes with, dealing with different situations. So the clinical judgment of the treating physician is one of the most important determinant for the successful outcome, not only in amyloidosis, but in all other things that we treat. Sometimes we make decisions which are very difficult and we go for those decisions. The situation in Pakistan might be different, and in South Asian countries is different. But here, the oldest person I have treated for mantle cell lymphoma, he was 93 years old when he came to my clinic, but I treated him with bendamustine and rituximab because this 93 years was completely fit, working in his farm. And, so there are geographical variations. There is you look at the patient. In the United States, they have done allotransplant for patients in their 80s, which in many jurisdictions they would not consider even autologous transplant above 60 years of age. So, all those things do matter. So if the patient is low risk, where is younger than 70 years, our own cutoff for autologous transplant is 70 years. We go 1 or 2 years beyond, depending on the performance status and organs and everything. But if it's in a younger than 70 years old patient, ECOG performance status less than 2, blood pressure not, systolic blood pressure is not low, is greater than 100, and other parameters listed here, then you can consider bortezomib-based treatment if the bone marrow plasma cells are greater than 10% and other organs are intact and patient wishes to have the treatment. You can consider starting bortezomib-based treatments. You could do direct autologous transplant also in younger patients. Or sometimes if the transplant is going to take time, then to debulk, we do Cyborg-D kind of treatment. If we don't achieve enough responses, we do consolidation treatments while waiting for autologous stem cell transplant. In the intermediate risk patients, where there is more kind of staging, stage 2, 3, and if there are other cardiac stage 1 to 3, or patient is ineligible for autologous stem cell transplant, then we prefer Cyborg-D with daratumumab. Now, if daratumumab is not available, then you can do Cyborg-D, you can do bortezomib with melphalan-dex, you could do melphalan-dex, lenalidomide-melphalan-dex, cyclophosphamide, lenalidomide-dex. There are several combinations available, and there are more options which are being evaluated, including carfilzomib and venetoclax. Venetoclax is, a good treatment for chronic lymphocytic leukemia. We have used it in acute myeloid leukemia with azacitidine. So this treatment is also upcoming. And in the high-risk patients, you have the same options like intermediate risk disease, but you have to monitor first. Start with the reduced doses because the cardiac functions may be more challenging or other organ functions may be more challenging. So you do those initial assessment, do intensive monitoring, start slow, and then you can go to the options that I mentioned for the intermediate risk. Supportive therapy is very important, including, management of the cardiac issues, neurological issues, nutrition support, organ transplants, including heart transplants, or kidney transplants and those things. I know that most of those things are very difficult to be available in Pakistan, but the trainee hematologist or practicing hematologist should be aware of these potential options if somebody desires to have those. So to conclude, it's an heterogeneous disease, difficult challenges for diagnostic and treatment. Accurate typing of systemic amyloidosis is very important. The therapies for AL amyloidosis are often multiple myeloma-like treatment, Cyborg-D kinds of treatment. Clinical trials, if available, are preferred. Autologous stem cell transplant in eligible patients, either upfront or after initial debulking in eligible patients, and supportive treatments are very important. And with that, I'm reaching my allocated time of 20 minutes. I would like to thank Pakistan Society of Haematology again. I thank the listeners, and I would like to say again, Pakistan Zindabad, and thank you for the listeners. I appreciate your time and your attention. And I hope that I would be able to contribute to these activities and to other professional activities. Thank you, and Assalamu alaikum.
Thank you very much, Dr. Aslam. So that brings us to the end of all the invited speakers' talks. I'm now going to start off with the question and answer round, and since we are short of time, I'm going to limit the questions to 1 to 2 per speaker. Can I have Dr. Shabih Haider, one of our presenters of free paper, the one who presented on autoimmune hemolytic anemia and CLL. So there is a question for you, Dr. Haider.
Yes, ma'am.
There are two queries from Dr. Syed. The first query is that in your study, Dr. Syed wants to know about the controls for the direct anti-hemoglobin test that you did, particularly in older age group, where we may find positive DAT as an incidental finding. So that's one. How did you make sure that that was true positive? The second was about the reliability of using LDH as a raised LDH marker in CLL with a high cell turnover. So those are the two questions for you.
Okay, so I already mentioned that in the exclusion criteria that all the patients with known autoimmune diseases such as systemic lupus erythematosus and Graves' disease and rheumatoid arthritis, I tried every possible effort to exclude all those studies which could lead to a false positive Coombs test. So they were already excluded from the study. So we could only target the autoimmune hemolytic anemia and CLL. That other autoimmune diseases were basically excluded. So the chances of false positive that were minimized by excluding the other autoimmune diseases. And ma'am, can you repeat the second question, please?
LDH, using LDH as a reliable marker for high cell turnover in CLL.
Okay. Basically, for the diagnosis of autoimmune hemolytic anemia, I relied mostly on the Coombs test, but I relied, as I mentioned in the diagnostic criteria for autoimmune hemolytic anemia, that there was Coombs test and there were 2 other signs of hemolysis. So I also incorporated the direct and indirect bilirubin and also the presence of the schistocytes in the peripheral blood film. So all those things were taken into account while labeling it as autoimmune hemolytic anemia. So serum LDH, it is a non-specific marker for the hemolysis, but that's why I took it in the minor criteria. Main was the Coombs test, and it was taken as a minor criteria.
All right, good enough. Thank you very much, Dr. Haider. Dr. Shahzad, the next question is directed to you, and this is a typical developing country question. The question is that, we still have affordability issues of using rituximab in aggressive lymphomas. So what would be your take on chemo regimes minus R in patients with aggressive lymphomas? How do you think the survivability of these patients would be if we omit R in aggressive lymphomas?
Thank you very much, Dr. Natasha, for asking me that question. And honestly, I feel myself deficient to answer this because I've just started practicing in Pakistan for last 1 year or 1.5 years. My mostly experience is from outside the country, and honestly, we never thought of anything without rituximab. Here, honestly speaking, sitting in the clinic, the major issue is financials and patients who are coming. It's a nightmare, honestly, and your heart bleeds to see. I just saw a patient, 18-year-old girl with M3, and very treatable, and his father is just So honestly, I can't share much experience of treating without rituximab. I think you can, or Dr. Usman can.
But you've had a pretty good experience with R prior to your experience here in Pakistan.
I'm sorry, I did not hear you. I'm sorry.
So you've had a pretty good experience with using rituximab prior to your experience here in Pakistan,
Exactly,
back
exactly,
outside the
outside
country,
the country, yeah.
comparable with international standards.
Exactly, and that's what I was surprised to listen to Dr. Usman about Burkitt's lymphoma. You know, we have a very good experience, almost 90% cure rate. I was surprised to listen to his comments that it has got a very poor outcome, even HIV positive. I just remember few cases, and one of or two are only died out of 10 or 20 patients we have dealt with, and that was HIV positive Burkitt's. Otherwise, they were got very good response. So I was surprised to listen to that part.
All right, thank you, Dr. Shahzad. We move on to Dr. Usman now. The question from you, sir, is how differently do you treat double espressors with double hit? So is the question for triple espressors and triple hit. Is there a difference in their treatment? We know about their expressor status, but also does the treatment also differ based on this?
There is again dilemma. The issue is that the FISH facility for CMIC and BCL2 and BCL6 is not available in, at least in my hospital. I don't know what is the status in other provinces. So that's a big issue. So number one thing is that the double hit is just 8 to 10% of the total DLBCL, whereas double expressor is reported up to 35% cases. But as far as the management is concerned, yes, for double hit, we always, because before this pandemic, we used to send the sample to USA for FISH analysis via courier to know about this stressor. So initially what we do, the first cycle we give R-CHOP and then we send the sample. And once we receive the results, then we treat accordingly, according to the status. On the other hand, double expressor, which are more commoner than the double hit, although the overall response is inferior, even with CMIC, only CMIC positivity showed inferior response compared to negative status of de novo DLBCL. We treat double expressor in the same way as the standard care R-CHOP.
All right, thank you. So I have the last question. That is for Dr. Waqas. Dr. Waqas, the question is that can you briefly give us a risk stratification for patients who require allogenic stem cell transplant in CLL?
Right. So as things stand now, currently, allogenic stem cell transplantation is going down and down in the list of treatments currently available for CLL. So I can probably remember only a couple of patients in the past 2 years who I have been involved with who had allogenic stem cell transplant. So to cut a long story short, if someone who is young and fit and has 17p deletion, we would consider that patient for an allogenic stem cell transplant up front. After obviously an initial therapy, if we have access to ibrutinib, we'll certainly treat them with ibrutinib. And because in the current scenario, having an unending course of treatment with ibrutinib is financially very toxic. So we would work them up for an allogenic stem cell transplant. And then, once the disease is under control and we have a donor, we will offer them an allogenic stem cell transplant. We will always go with a reduced intensity conditioning approach. And in our center, we go with a T-replete type of a transplant. So that provides to us, we think that provides a better GVL effect, although we do get slightly higher rates of chronic GVHD. But I think we pay that price to get a longer term disease control in a very poor risk condition. So in summary, just the 17p deleted patients, will offer them allogenic stem cell transplants. Others will go with our other standard chemotherapeutic approaches.
All right, thank you very much. That wraps up session 7 on the lymphoproliferative and plasma cell disorders. We've had a very informative session. I hope all the audience has had it too. Please stay tuned for the upcoming industry session in the next 10 minutes because we've overstepped our time, but please stay tuned for that. And everybody else, please stay tuned for the rest of the conference. All of us, we're signing off, and this closes our session 7. Thank you very much, and Khuda Hafiz.
Thank you.